Let's have Dr. Jaiya. Dr. Jaiya, you know why I included you is not that your hard work was not implemented by the Punjab government. Still, it is gathering dust, and as well as with the Niti Aayog. But during the process, I was part of this process, and you did such an exhaustive exercise. Could you give a snapshot of what the regulatory framework is like to be? Is it going to be, excuse me, I'm telling a bureaucrat, a typical bureaucratic approach to the problem, thinking of negatives first, or they will open up? And second thing is, with your experience of these two startups, what do you think is likely to be response? And the term used by Akash is the what would be the organic growth of telemedicine or virtual medicine, whatever you say. Back to you, Dr. Jaiya.
Thank you, Dr. Bhandari. I think if I look back at my experience in remote rural areas in India, then even as a deputy commissioner of a district in Arunachal Pradesh, way back in 1985 to 1988, I was at a place where there was not even a telephone connection as the deputy commissioner of a district in India, mainland India, where I had to be airdropped by Air Force helicopters, or I had to go along an uncertain track, which was an earthen track for some 200 kilometers, which took me 10-12 hours, after which I had to stay the night and then walk again along the road route, which was still being developed, for another 50 kilometers, which in the best of circumstances I could do in 12 hours or so. So from those days when we had nothing, today in that same district headquarters, since I'm still in touch with the current deputy commissioner in that place called Anani, he still is asked by his own state government that why does he not reply to an email message for 2 weeks. He says, my net connection is so poor and my cell phone connection is equivalent to only a 2G connection. So we have enough places in India where you do not have more than a 2G connection. So if you are looking at the last mile, you are essentially looking at 2G, not even 3G. Now, if you go even in a normal village in India, out of 10 people, roughly 1 or maximum 2 would have a smartphone where they can use WhatsApp. And the other 7 or 10 will then be able to access that single smartphone, which may be in a pharmacy shop or some other person. It may be A&M, it could be whoever, which means they do have access to a smartphone, and within a, let's say, 102 meters, 200 meters of wherever they are. So then you realize that while on one end we are talking of high-end platforms, so if I'm CEO of one company that is virtual Sathi, and that is modeled on lines similar to what Akash has been talking, AI-based ultimately. But there again, we are realizing that we have to actually give our software, EHR, etc., to a local area network in smaller setups of NGOs deep in the interior who are doing work on health. So which means they have a local area network and they install our software there, and we maintain it from a distance with an AMC. They keep the data with them and they do whatever they want. If they want us to centrally keep the data, then of course we are delighted, because that gives us the larger data set to then, even when we have firewalled it amongst, let's say, 100 NGOs, to combine it for deep learning purposes, AI-driven solutions like Akash is already working on. But if I look at my experience of the last 2 days with the helpline of a TV channel called Aaj Tak in India, which is the Hindi counterpart of India Today. So we are part of a large group, Aims to Health senior doctors. 7 of us were yesterday with them on a TV show introducing them to this new 4-hour helpline, in which 500 doctors would be present online, of which 10 are from our firm, Aims to Health, limited. And we have repeated that today also for 4 hours. So our experience is that the nature of the problem and the nature of the solution that you need in those areas has absolutely nothing to do with the guidelines issued by the Government of India or by AIIMS New Delhi or by ICM or by Apollo, which means these are city-centric guidelines. They do not take into account the reality of the rural areas. So if I'm talking to these people in a remote rural area on a phone, which means I don't see their face, they don't see my face, they trust that I'm a good doctor simply because they trust Aaj Tak. So it's the brand of Aaj Tak. I am nameless, faceless, and I'm only on a phone line. And if some of them happen to have seen the program that day in the preceding hour, then of course they know who the guy with the turban was on the screen, and I say I'm the same guy. So they can relate to my face. But beyond that, they don't really comprehend what is AIIMS New Delhi or what is the capability of any doctors in our team. So if we say you have to, if you have nothing and you are at home, and so you have to be in home isolation. Now, these people are generally speaking in 1 or 2 rooms in the rural setup. Sometimes only one. And then one person, when he falls sick, he's actually shifted to a thatched hut outside. And in that thatched hut, if he served anything, he's served by tying it to a long pole, which is then delivered to him. And even though he's asymptomatic for all practical purposes, even on the 14th, 15th day, they continue to do that, not knowing that he is non-infectious after 10 days. So you can see the communication challenge with these areas, that they have not heard about anything. If state governments have made protocols which require government doctors to prescribe medicines which we all know have no role whatsoever. So for example, the state government of Uttar Pradesh, till I last saw their circular, still has 3 top medicines which include doxycycline, azithromycin, and ivermectin as part of a standard prescription for any patient of COVID or suspected COVID, irrespective of the time or seriousness that he presents himself or herself. And this therefore is causing more problems than others. And in the urban areas, this is definitely causing QT prolongation in some patients. So instead of helping, it's causing nausea, vomiting, and QT prolongation. And if you stop all these things, people recover. If you continue these things, they are sick. So in these rural areas, well, fortunately, they don't have most of this, but then they don't even have a thermometer. And you can't therefore talk to them of an oximeter because they have no way of getting an oximeter. So if you don't have a thermometer, if you don't have an oximeter, then you have to teach them how to count respiratory rate. So you first ask them, "Saans phulti hai ki nahi?" in the local language, whether you are out of breath or not, on at rest or after walking a few steps. So most of them may not even have a watch. So counting 6 minutes makes no sense for them. So talking of a 6-minute test or trying to explain its niceties to them and of an oximeter, you are totally out of this. Now, some of them in remote rural areas or urban slums do have surgical mask at best. And some of them are smart enough to use a mask morning till evening and discard it. So even 17-year-olds are capable of doing so. And even though they are, their father is only having a roadside thela on which he sells pani puri. But the boy is articulate enough to ask me these questions, that if I have a 2-room house in which I live, how should I manage with home quarantine? So which means the level of understanding of people in this category is fantastic. Even in Delhi, a gardener, a Mali as we call him, who earns barely 9,000-10,000 rupees, who did not have oximeter for 5 days, someone gave an oximeter to him. Not only was he using the oximeter, even though he's practically illiterate, he was maintaining the chart almost as well as any trained nurse would do in terms of recording the oxygen level, the pulse rate, and temperature. and any particular issues on that day. So yes, he has a smartphone given to him by somebody. So with that mere management, this man is able to send me pictures of all the medicines that I have prescribed. He is able to give it to the wife. Both were very sick. She was extremely sick. Her oxygen levels in her oximeter were consistently less than 60 for 2 full days. She went to 5 different Delhi hospitals. She could not enter the main gate of the hospital. Why? Because they were considered to be too poor to be even let in. Why? Because the hospitals were overflowing with patients, because even those who are well off cannot even get in. So I have patients whose children earn packages upward of 50 lakhs, who went to hospital, had to come back with their father and grandmother, both of whom had oxygen levels around 80%. And managing them at home was not a challenge with an ordinary oxygen cylinder or the concentrator. But in this gardener's case, there was no oxygen. So all one did was give her a medicine which cost 2 rupees per tablet, which is dexamethasone, and twice a day. And for within 3 days, her oxygen levels had gone back on the same oximeter from 60 to 80 in 1 day, and 90 in the second day, and 93 in the third day. And in the next week, she maintained herself at that level throughout. And in terms of history taking, what we have done is we have written a 3-page form with questions, which they can either print out, or if they can't print out and fill it in, they can note the question number and against that write whatever, whether by voice recording or in Hindi or English or any other language. Well, in our belt, most of these people have been doing it in English and Hindi. So the net result is that you have one set of people who can only do it with you on an ordinary phone. So it's a challenge even sending this to them. But you can ask them questions, they will answer correctly, as well as you and I would answer. And they are not educated. The second set is who will note down the questions and answers and put the number and WhatsApp it back to you. The third set is who have an access to a printer, directly or indirectly, print it and then write against it in longhand and send a photo on WhatsApp to you. A fourth set is who work online, who create a proper digital document and send the document to you. A fifth category is who put that document on Google Drive and send you a link on WhatsApp. And within these various categories, there are people amongst them who, for example, send me a list of questions every day that they want to ask me about the patient's progress. They then have a 15-minute or half-hour session with me on the patient. These are youngsters in their 30s who are doing this for their father or grandmother. But even 50-year-old women who are otherwise, let's say, teaching English somewhere are sending me a half-a-page note explaining on the WhatsApp what medicine was given at what time, what did the patient eat, what were the challenges during the day. Once a day, I'm given this input in writing. And the smarter ones are putting it on the digital form at one place where I only get a link. So this kind of monitoring is possible for at least 10 to 20 serious patients who otherwise should have been in the ICU at home. And some of these patients are, one is a hemiplegic, the second one has chronic renal failure. Most of them have diabetes. Some of them have poorly controlled diabetes, and all of them are on steroids. So the common thing amongst them is all of them are steroids. Some are getting oxygen sparingly because they get a small cylinder which lasts even at half a liter per minute speed only for an hour and a half or 2. So if they run it at full speed, which means 2-3 liters is what the patient needs, then it goes away in 1 hour, but they have to wait in a queue for 7 hours to get the next refill, which lasts 1.5 hours. So if the family has 2 people, nobody can go. If both are sick, there is no one to cook, which means you also now need to help them with someone to supply them everything they need. So I'm working with 3 NGOs. So one NGO will probably end up giving them oxygen cylinder. Another one would be giving them a concentrator. A third one would be lending them on a returnable basis a oximeter and a thermometer. And a fourth one is giving them either rations if they are able to cook, otherwise cooked food. And of course, neighbors are giving one meal and office colleagues are giving the third colleague. So there are people earning 50,000 rupees who are in debt because they did not have 1 lakh rupees ready with them to pay for the rental of an oxygen concentrator. And also the upfront payment for using it for 10 days, 80,000 plus 20,000, 1 lakh. They had at best 50,000 with them, and now they had no money left for medicines or anything else. So which means you also give them food, you do everything. And you do it at a cost which is negligible. And if on social media or any of these NGOs, if you get to them, you are able to do everything without any difficulty with results which are absolutely unimaginable. So what I'm trying to say is the world, I cannot put them out till they at least complete 1 month. And most of them have completed 3 weeks. And of all these people, only one had to be sent to hospital, but within 6 hours of his coming to me because he was uncooperative, young, no comorbidities, and they were keen to take him to hospital. And they couldn't naturally find a hospital anywhere near. They were well connected, very rich. They took him all the way to a city called Nawashahar in Punjab. They drove through the night, reached at 4 a.m. He was in a wonderful ICU, lasted 15 days, but in the ICU, they were giving him, instead of 8 milligrams dexamethasone, 20 milligrams dexamethasone, because that seems to be the consensus amongst the intensivists working in ICUs in Punjab. So this is what I'm seeing happen. I have patients where they have been started on 1 milligram per kg body weight methylprednisolone on day 1, simply because their CRP levels were raised to 40 or 50. Or because they were old and they had no comorbidities. So which means these are cardiologists, nephrologists, internal medicine people, and sometimes pulmonologists who are doing these kind of funny things in India, which I just can't comprehend. I mean, if it's an illiterate, ordinary doctor who went to an ordinary college and hasn't had the time to look up anywhere. So Randeep Guleria, for example, as director of AIIMS and as a key figure coming on TV so regularly, keeps harping the fact that they should not be giving any steroids in the first week unless oxygen levels fall. It doesn't seem to make any difference. People are so blind that they want to take on, all kinds of things. Even a very famous cardiologist in Delhi who has been propagating the use of steroids from day 1, who runs an NGO, and that NGO therefore also has been giving steroids from day 1. That same cardiologist now has ended up in an ICU because of his own deeds himself. So this is the situation in Delhi. And if we are looking at the last mile, there is last mile in Delhi also on all aspects. So today, for example, in one of the helpline cases in Rohini in Delhi, I had a call from an elderly lady around 80 years of age saying, I have gone and taken both my shots, first and second. My husband, who's 85, cannot climb stairs. He can neither go down nor come up. We are on the first floor. So how can I get the vaccine? This is bang in Delhi. So now I will have to find a way to get the vaccine for this old man who's only asking me how to get it, not whether or not and this or that. So if this is the last mile problem in Delhi in relation to vaccination, for the elderly who are high risk, who are the first priority, then you can imagine what is the situation in Delhi. Then another patient came to me again because someone gave her number because he saw her sitting on a charpa in the street in Paharganj in Delhi. And her only request to me was, I have no money to buy oxygen for my cylinder. I don't have corona, but I have chronic obstructive pulmonary disease for which I was hospitalized. And now that cylinder is khali every day. Otherwise, I would be given by passers-by or the open shops something worth 200 rupees, 300 rupees, which took care of all my needs. Now I don't have that income. My brother who lives in the house, who's thrown me out, drinks 3 days a week. Next other 3 days, he earns 300, out of which he gives 150 to the wife with 2 children. We have not paid electricity bill for the last 6, 7, 8 years, which is 18,000 rupees. So we are living in darkness. So kindly, can you help with another 2,000-3,000 rupees so that we survive for a month? Now, this is happening in Delhi, where Kejriwal says anyone who has any problem will solve it. So, which means the last mile problem, not just on health, on every scheme under the sun, is there in Delhi even today. The Mohalla clinics, which were the famed Mohalla clinics, don't seem to exist anymore. So if this is the last mile problem in Delhi, then imagine the problem in remote rural areas, where someone from a village in one district of Rajasthan called me to say, because he knew the DSP of Mahendragarh district in Haryana, who was related to him, that his relative is admitted in the ICU, and I don't even understand what the ICU guys are trying to tell me. They get no feedback from the patient, of the patient to the relatives. The nurse fortunately came on the line, so I know what was being done. And all I can say is that the treatment being given in that Sarkari ICU was not in conformity with the state government's guidelines, because the state government on paper is following the central government guidelines from 22nd of April. And this is I'm talking of a discussion after that. And I know why the state government is doing that, because the advisor to the chief minister is a batchmate of mine. When I asked him, are you still giving ivermectin, azithromycin? And so to cut myself short, what I want to say is that civil society and startups in India are doing a fantastic job. So we have, for example, My Upchar, which is doing a massive job in Hindi, in UP and neighboring states. We have Jio, JIYYO, again by another entrepreneur, young boys, who's doing through the so-called village Jhola Chhap doctors, work at the village level in a manner in which the Jhola Chhap doctors are part of the solution, and in a system where the MBBS doctors are a part of the problem. So this is complete reversal of what you normally talk of when you say the doctor is the solution through telemedicine. Here I am saying, no, even the doctor is not the solution. It's the local person in the village who is the solution.